Alrighty. So, good evening, folks. I'm Danica Abbin, class of 2011, and I am the programming co-chair for the Association of Black Princeton Alumni. Tonight I will also be the moderator for our event entitled Health Equity in the Age of COVID-19. Some of the topics for this evening, Some of the topics for this evening will include the initial impact of COVID-19 on Black communities, vaccination, education, and distribution thus far, and how we can continue advocating for each other during this pandemic and being prepared for the next public health crises. So to address these items, we've invited two alumni speakers, Dr. David Kountz and Professor Keith Wallow. Dr. David Kountz is co-chief academic officer and vice president of academic diversity for Hackensack Meridian Health. During the pandemic, in his position, Dr. Kountz has hosted vaccination seminars with a focus on building trust with targeted outreach to his local community. Professor Keith Wallow is Henry Putnam University Professor of History and Public Affairs at Princeton University. And he is also the current president of the American Association for the History of Medicine. Professor Wallow, using his extensive work in science, race, and health equity research, has focused on situating COVID-19 in relation to past and current public health crises that disproportionately and negatively affect the Black population. So it's a pleasure to have you both with us tonight.
Good to be with you.
Thank you for the invitation.
All right. So the format for tonight will include about half an hour of structured discussion with prepared questions. Then we'll open up to the audience for a couple of Q&A questions. Those will be done via the chat, and I will read the questions out and then allow each of the panelists some time to answer them. Give each of the panelists a chance to answer. So after that, we will end with closing remarks from each of the speakers. So Professor Wallow, is there anything from my introduction that I've kind of missed or that you might want to touch on?
No, you were fine. And the introduction was great. Thank you.
Awesome. Dr. Kountz, same question.
No, perfect setup.
Awesome. Okay, good. So I think the first thing that we wanted to kind of talk about and focus in on was the initial impact of the pandemic. So Professor Wallow, within the context of previous health crises, can you discuss some of the disparities in how COVID-19 has impacted Black people in America?
Yeah, well, thanks a lot for the invitation to have this conversation. And what I would say is that the pandemic is really, it's told two stories so far. There was the story of 2020, and then there's the story, as you suggest, kind of post-vaccine. And in some ways, they're very different stories having to do with race and racial disparities, Black-white disparities. I think the story of 2020, just all by itself, is one in which you saw excess mortality. By some estimates, Black people died like 1.4 times the rate of whites across the country based on sort of early data from this year, looking back to 2020. And, by the end of last year, the story was pretty much set that the disparities in both infection rate, hospitalization, and mortality had really revealed the kind of structural inequalities that cut across a lot of different factors, like Black people being more likely to be essential workers, not being able to do the kind of remote work that I can do from my little cubby right here at home, living in dense housing circumstances that make if the virus far more brutally efficient. Then you have public transportation, living in multi-generational households. And, historically, these are the kinds of things that we see, whether it's cholera in the 19th century or plague, that is the disproportionate impact on people because of the brutal efficiency by which certain kinds of contagious pathogens are spread. On top of it, what you had if you have with COVID is a disease that disproportionately singles out the elderly, who, if you're like a grandma or a grandpa living with the other generations, you're at higher risk. And then, of course, the higher condition, the having conditions like diabetes and hypertension. So it's kind of a layered atop other vulnerabilities. So I'd say that's the story of why we saw the disparities we did, and how it kind of revealed what many of us knew existed in a particularly tragic way.
Yeah, there's not much to add. There was a sad but perfect, exact summary of what was happening. I remember caring for patients in that first wave, when we still did not fully understand how the virus was transmitted. I think that was perhaps the other thing I would offer. We now are very confident, it's respiratory. We understand about social distancing, more clarity around masks and other approaches. But if you all remember, in the very first couple of months, there was uncertainty. Was it on surfaces? Did masks work? And I think if you, in addition to what has already been said, have a population that is a little bit suspicious, has not been treated well by the healthcare community, there is going to be even more distrust, not even getting to the point of vaccination distrust, but just distrust of what was being told and who were the messengers. And I think that was a smaller component, but I do think it was part of the, this lack of trust as we moved into, yes, it's respiratory, yes, wear a mask. We had among Black people kind of less connection to primary care physicians, individuals who receive more routine care in emergency rooms, for example. So you didn't have the benefits of that, I'm going to say, doctor-patient or provider-patient relationship. And I think that contributed to some of the excess morbidity and mortality early on as well.
Speaking a little bit more actually to treatment by the medical profession, did you see, Dr. Kountz, did you see something in terms of the difference in care, or how people, when they came in and they were asking about whether they were sick or they were trying to kind of find out more information, did you see kind of a difference in how things were communicated?
Yeah, I'm not sure I can say I saw, but I think no doubt there was a perception, talking to patients and hearing patient testimonials, that there was, those barriers that frankly have existed and were exacerbated during COVID. Kind of this lack of connection between caregivers and providers was probably exacerbated. We know that physicians and other care providers who have microaggressions, or implicit bias against populations that's picked up by those patients, and those individuals perceive their care is less effective. The recommendations are followed less regularly. The amount of time that physician may spend is less. The confidence that patient has is less robust. We've seen this before the pandemic. We've seen it after the pandemic. So if you take this, again, kind of this early wave of incredible anxiety, you don't have trusted messengers. You don't have your own doctor. You're getting care in an emergency department with a population of providers that may harbor some implicit biases. It kind of sets up for both a perception of and probably the reality of less high quality care. So I think all of the elements were in place, unfortunately, that we saw the results with the pandemic.
Sorry, I believe I was on mute. An additional question, I guess, as a follow-up to that is, what has the medical profession begun to do at this point to address some of these concerns?
So before the whole group joined, I mentioned that one of the great joys for me in the last 5 years has been part of a team to start a new medical school. And we believe very strongly in learning with and from the community. This goes back to our charter and our first mission in 2016. And so we take that mission very seriously. And I think many other schools are doing so as well. So my answer is around the generation of future physicians and a commitment today to working with the community. So just one specific example of what I'm describing. So we place our students out in the community. We place them with individuals or with families to make the point that healthcare is not only what happens within the walls of a clinic or a doctor's office or a hospital. We spend a lot of time teaching the social determinants of health. So we believe, and we think many other schools are taking this mission seriously. So I'm hoping to answer your question by saying that future generations of healthcare providers are going to have education that is much more meaningful in understanding social determinants and how important they are to the highest quality of healthcare delivery. How that impacts current providers, I think is harder to say, but I think that the curricula of the next generation is changing to address these issues.
Really good to hear. Professor Wallow, in terms of kind of putting this into context, have you seen, I guess, based on what you've seen with public health crises in the past, because I know that you've done some studies there, have you seen differences in terms of improvements in how the pandemic has been dealt with, or have you seen any history repeating itself, or what are some key things that we could take note of in particular to COVID-19?
Yeah, I would say both, actually. I mean, the historians like to say that history doesn't so much repeat itself, but it does rhyme. That's kind of borrowed from Mark Twain, decades and decades ago. And so, for instance, during the initial phases of the influenza pandemic more than 100 years ago, there was a kind of confusion about what the data said along lines of race. There were some cities that claimed that African Americans were more likely and more vulnerable to the ravages of the flu pandemic. And there are other cities where the experts said, no, Black people are less vulnerable to the ravages of the flu pandemic. And then there were cities basically that said, well, there's no difference between the two. You saw similar kinds of hand-wringing over issues like polio pandemics. But one of the themes that does replicate itself is, I mean, it's a very simple point, which is the speed of the nature of transmissibility in the infection rate will translate into and the vulnerability that already exists in a community will accentuate and aggravate disparities. And that's true in the cholera years in the 1830s, 1840s, and 1860s. It's true in influenza, it's true in polio, and it's true in HIV/AIDS, and it's true today. So, but one of the things I think is very important with COVID is to not take the social differences that accentuate and aggravate differences in mortality. We ought not to take them as a given. So for instance, communities with high asthma rates, asthma rates don't come about by accident. They come about because of poor housing, exposure to cockroaches and unhygienic circumstances that put people at higher rates for respiratory disease. So if you want to understand how how vulnerability is layered atop pre-existing situations. It's not just questions of like diabetes and diet or hypertension. It's also the social situation. I just wrote this book on the history of the tobacco industry and targeted marketing. And the idea that smoking rates didn't just like change out of only because people's behavior changed. That actually has a lot to say about how inequalities get structured in our society. So I guess what I would say is that what we see in COVID is the end result of a long sequence of disparities in residential opportunity, in employment, in access to healthcare, and in the deficits that visit communities in relation to things like, yes, diet, and yet, yes, lifestyle, but also social circumstances. And at least here, there has been a good conversation about this. And Dr. Kountz referenced George Floyd. I mean, the sad convergence between COVID-19 and the murder of George Floyd, coming after many, many other such murders, at least has opened this kind of conversation. So that I think for the first time in my lifetime, we're actually having a conversation, not just about the pandemic, but about the convergence between the pandemic and really long-standing racial inequality.
A lot of sense. Like I've heard discussions a lot about comorbidities, and this is actually I feel like it's putting comorbidities in the context of what has happened before, because things don't just happen. So I definitely hear you with that. So I think I wanted to discuss a little bit about vaccines and vaccine hesitancy. And I think Dr. Kountz, I wanted to talk with you a little bit about that initially. So what has been your experience, I guess, thus far with vaccine hesitancy as you've been like in your position?
So I had many conversations with individuals, with groups, with community groups, with churches, with our own employees or team members around vaccine hesitancy. And I would say that in comparison to the very beginning, the rates of hesitancy or the differences have narrowed over time, but there's still more hesitancy among people of color. I say that with a little bit of caution, because the statistics are not universal as to who reports that they didn't get vaccinated. But I think it's certainly generally understood or believed that there's more hesitancy. And I think it's for the reasons that all of you have heard about largely. Early on, it was distrust. It was some of the things I mentioned earlier. It was a lot of messengers who were believed in the Black community, who were perhaps not healthcare providers. Probably an important related comment, just to take a small tangent, is African Americans in New Jersey represent maybe 13% of the population, with 4% of the physicians. So there's a huge disparity, even if you just wanted to look in a particular community and find a physician of color. It's just very difficult to do that. So we had messengers who were trusted for some of the reasons we had talked about. We had a lot of access issues, some of the things the professor mentioned. If you are an essential worker and you hear about even in my world, mild side effect that might cause you to have a headache and feel lousy for 6 hours, if you're an hourly worker, you may lose your job if you don't show up. You can't get a ride to the vaccination center. I remember early on, there was a lot of excitement, admittedly so, for drive-through vaccination. Of course, that left out people who didn't have access to a card. and we were disproportionately more likely to be in that situation. So early on, it was access, it was distrust. Those conditions have improved, but there is still a gap that exists. And I think my own perception is there are many still hardcore individuals in terms of never being able to get them vaccinated that is going to be a challenge. We may talk about what some strategies exist that all of us can undertake to communicate the importance of vaccination.
Professor, I guess in relation to past public health crises, have you seen kind of similar trends in terms of access and in terms of distrust, and how has it been combated in the past?
Yeah. So if you don't mind, I'm going to talk about really what I've seen this last year in relationship to what you might call the uses and misuses of the past. So because one of the things that I as a historian have been doing is actually, doing history in the moment to try to understand the patterns. And so just to echo what Dr. Kountz said, the story of vaccine hesitancy is itself fascinating. So even early this year, really just when the vaccine became available, if you look at the data, what you begin to see is that, from January until March, you had a slow and steady decline in the people who said they would probably not get the vaccine, like going from 22% to 16%. The people who said that they probably, would not get it also declined. The people who, this is the general population, but there is this kind of core group of Americans, about 8%, that just essentially said, doesn't matter what happens, I'm not getting it. Right? I'm just not taking the vaccine. But even before the vaccine was available, you started to see this shift by demographic characteristics, where white hesitancy dropped from, let's say, 21% to 16%, whereas Black hesitancy, which was high at 34%, dropped 16 points to 18%. So what you began to see is a narrowing of what had been a starker racial divide in vaccine hesitancy, so that by March, you're basically seeing comparable levels of hesitancy. And so if you track the news story, the news stories of from April to August to September just now, track this transformation, where in April, the news headlines would say things like, why Black and Latino people still lag on COVID vaccines and how to fix it. By August, the story was, amid climbing COVID cases, and this had to do with the Delta variant and community efforts, racial disparities in vaccination appears to be narrowing. And by the end of the year, that is September, October, the story was racial disparities in vaccination rates have evened out, but there is a new partisan gap. That is to say, your party affiliation tells you more now about whether you believe in vaccination or not than race and ethnicity do. And the analyses, suggest it varies really dramatically by state. But one of the analysis, and the reason why I say the uses of the past, is that right in the middle of this, you had these anti-vaccination organizations like the ones run by Robert F. Kennedy that began to kind of target Black folks with misinformation using the Tuskegee syphilis study as if to suggest, to actually suggest, they were banned from Instagram because of this, to argue that this vaccination was just another effort on the part of US public health authorities to victimize Black folks. And so this kind of charge, which was threatening, ended up being answered by actually similarly effective pro-vaccination campaigns. So if you look at a recent like October New York Times article about why Black Americans changed their minds about COVID shots, what they argue, they say that, one reason was effective pro-vaccine campaigns. A second was the surge in vaccine hospitalizations because of the Delta variant, which threw a scare into everyone, especially the unvaccinated. And then the irony of this is what has also narrowed the Black-white vaccination rates is the continued resistance to vaccines among whites. So there is a story to be told about disparities declining that have to do with, and then you get individuals like, the former mayor of Tuskegee, right, who gets up and says, look, I used to be skeptical of, I'm sitting here, in Tuskegee, Alabama. I used to be a skeptic, but now I believe in vaccines. So we're still watching this story play out. And of course, we're facing a new threat of another variant right now. So, but it's a complicated story, this story of vaccine hesitancy. And the last thing I'll say is that in states like Mississippi, you're basically seeing Black Americans in Mississippi vaccinated at the same rate that you would expect given the population. So disparities exist, they're patchwork, but they have narrowed really remarkably over the course of this year, and who knows where they're going.
Really positive, actually, because
I think that was a terrific summary. I think the other thing that happened was we finally figured out the importance of getting out to where people are. So you saw vaccination campaigns in church basements. You saw vaccination efforts in high-rise housing. And we can't ignore the impact of time. So, I've probably heard hundreds of people say, I need to make sure it's safe. And as time went on, with rare exception, it was so overwhelming that the risk of contracting COVID outweighed the risk of vaccination that a strategy of going back and saying, can we talk again about the importance of vaccination? That tincture of time was very important. Getting out to where people were was important. And I'm glad that the experience I've seen, the professor has kind of sees nationally as well in terms of this narrowing of the disparity.
I guess in a little bit more about what you're saying about like that specific outreach, so you're saying that with the pro-vaccine kind of push and like public figures coming out was actually a positive in terms of like affecting perception. Do you think that it was larger public figures, or do you think it was kind of that more intimate one-on-one with your doctor and one-on-one in communities, or a combination of both?
I definitely think it was a combination. I was reflecting back on, the challenge today, of course, is that we live in a completely new kind of information environment than certainly I did when I was growing up, right? Where we had like, 3 television stations, 3 major news stations, right? Cable was new. Certainly the internet didn't exist, right? So the capacity for informing the public, but also misinforming the public is massive. And what I was able to track anyway is both the kind of misinformation that if you find its way into Facebook and these other media, but also orchestrated campaigns like on this program, like The Conversation with Kamau Bell, who teams up with physicians to really do public information campaigns to answer your questions about COVID-19 vaccines. And so in the age of the podcast, or in the age of the internet program, right? The celebrities that people follow on Twitter or on Facebook or wherever, like these, I think, are the vehicles for adjusting people's understanding and commitments to vaccination. And I think the other thing, I mean, I haven't really studied this yet, but you know, when you have such a blatantly manipulative anti-vaccination effort on the part of Robert F. Kennedy's group to use the Tuskegee syphilis study to try to, as I said, blatantly sow the seeds of mistrust. It almost called African-American figures, right, into the public to actually speak back to this manipulative, deceitful campaign. I should tell you one funny story, which is about 6 or 7 years ago, when Tavis Smiley was still on television and he had this program, they asked me to come out to LA to be part of a kind of a reflection on Black health, the state of Black health. And so I went out and I thought it was just going to be me talking about the state of Black health. And then lo and behold, I get on the set and there is Robert F. Kennedy sitting in the seat next to me. And they start off by showing a clip about Tuskegee. And he goes on a riff about why vaccines can't be trusted. And I remember sitting there thinking, why am I here? Like, how did I end up in this? And so I, of course, had to pivot into like vaccines are absolutely crucial for safeguarding, the health of infants from measles, mumps, rubella, tetanus, pertussis, diphtheria, but the idea that such an important figure like Tavis Smiley would have put Robert F. Kennedy even into the discussion, to me, was kind of shocking at the time. And so fortunately right now, what we have are a lot of responsible, thoughtful people who understand that there's a reason for, as Dr. Kountz was saying, mistrust. Like, it's a new virus. It's a new virus and it's a new vaccine. There was so much uncertainty about what this was. Could it be spread symptomatically or asymptomatically? The public is right to have questions. And so it takes a lot of like deft communication skills to cut past the misinformation. So that's a long way of saying that it's a little bit of both. High touch, person-to-person contact, seeing that your elderly relative got the vaccine and did just fine, knowing what the actual side effects are, as well as hearing from people who you trust.
No, that makes a lot of sense. And wow, it's actually curious to hear that that you were put in that situation where you were thinking it was going to go one direction and then it just completely shifts.
Crazy.
Was there ever any explanation from Smiley about why he would, if you will, ambush you?
I don't know. I can't say that I ever fully understood that, except that he himself may have harbored some of the same kinds of skepticisms about vaccines. That part was never made clear. Yeah, but it does speak to the fact that one of the things that this situation, this pandemic, has done is it's pushed a lot of these conversations into public, so that we have to grapple with them. And as unfortunate as what I'm describing is, it's better to have it debated out in the open, right? And to fortunately see things go in the right direction.
For sure. Speaking of, I think I have a couple more questions, but if anyone has some questions that they would like to ask after I continue, feel free to add them in the chat and I will throw them to our speakers. So, but for my next question, I guess, is as we're kind of moving into this next phase, we kind of have new variants popping up. We're not at the end of this, we're kind of in the middle of this. What can we do kind of as Princetonians, honestly, as just fellow people supporting each other? What can we do to protect each other as we move forward?
Well, I think the harsh statement is realize that this is over. I mean, as as we were talking, we were getting started, we have a new variant. There may be future new variants. I know that no one wants to hear that, but I think part of it is the consistent message of we can't get too complacent. I'm worried after this Thanksgiving weekend what we're going to see in several weeks in terms of families who may have been a little bit more relaxed with unvaccinated relatives joining. Let me answer kind of one last way around engagement and research. One of the messages I had that I hope was important when we started our education and our conversations was that we were very intentional. We studied the Moderna vaccine in one of our hospitals and the J&J vaccine in another one of our hospitals, and we made a conscious effort to recruit underrepresented individuals into those studies to make the case that it's very important to be part of the solution. And one way we can do that is by being open to and engaging in research. So I think it's realizing that we haven't hit that threshold that we hope we will hit at some point in the near future, to not let one's guard down, to take advantage of boosters. I think sometimes this message around boosters is confusing. I get it. Why do I have to get a booster? I was told that 2 shots was all that I would need. Unfortunately, a lot of this science is playing out publicly that otherwise would have just been discussed at various meetings, and then there would have been a recommendation. And now we see it on Facebook, and we see it every hour on the evening news. So it is that kind of frustration I'm sure many individuals have with different recommendations and different messages and different messengers. But I think it's engagement of research, engagement in taking advantage of boosters, and still social distancing. And I guess taking advantage of testing, something we haven't talked about, is more and more availability. We don't hear a lot about doing rapid testing, but that's still an important way to identify individuals who are ill and removing them from those other individuals in our lives, that elderly member who's living in our multi-generational household. So there's still a lot of those tools out there. We just need to be reminded of them.
Yeah, I would say that what we can do going ahead, it obviously depends a lot on what happens next. The pandemic is, this virus is a cruel teacher. And in some ways, it's the cruelty and the tragedy of the Delta variant that kind of pushed many people past vaccine hesitancy to, and I would say that the current variant is probably going to have a similar effect. We've learned a lot as a community about, as a society, about just very simple things like how viruses evolve, and that you can't take for granted that it's just one thing that once you vanquish it, it's gone. And I think the broader thing that I would like to see is a continuation of a more positive conversation about what people owe to each other. That is to say, what kind of respect is owed to each other, that my safeguarding my health is also safeguarding your health. That we don't, that like watching out for other people, which has been kind of part of, I think, a broader public conversation, although sometimes it's pushed in the background by the anger and the hostility by people who are vaccine aggressive about vaccines and masking. And so I guess what I'd say is one of the best things one can do is to not be part of the problem. And that's a big step. And then also to be part of the solution. And that is to sort of help people who really need support. in this time. And I think all of us have done versions of this, right? Whether with your older relatives, with your with your parents, with other people who are in more vulnerable than you are. So, I think that if you can strip away the nastiness of life in pandemic times, I think if you were to look back, I would like to say that people will look back and see the beginnings of a more robust public health system, a society where people actually care about each other a lot more, and those sorts of things.
So kind of dovetailing off of that and moving into kind of thinking about things kind of more structurally, one of the questions that we have in the chat from Charles Anderson, Dr. Charles Anderson, apparently great class of 83. So he asks, what can we do to make sure that the current focus on health equity and the realization that inequity is the upstream issue that needs to be addressed, instead of simply continuing to talk about the downstream disparities, continues past this pandemic? So it feels like we've started, but how can we continue to make sure that this gets focused structurally and is more of an overarching change versus kind of individual responsibility?
So I'll start. I think it's a really important question. I think part of the answer is it comes down to what's good for business. And let me explain what I mean by that is, I think I think we should try to rely on goodwill and many of the social constructs around caring for, someone else in society. But I think structures need to put into place either a significant incentive to or disincentive not to address health equity. So in our system, we employed a digital platform in our electronic record so that any patient who's admitted, as we're rolling this out in our hospitals, we can get a perspective of where they fall in terms of their social determinants. And this will trigger an appropriate referral for access to healthy foods or transportation assistance. So we built into our system a way to monitor and hold physicians accountable to address social determinants of health. So that's just one example. I think we have enough sophistication, one, to realize that social determinants can be addressed from my view of the world in the healthcare system, and that those who pay the bills should incentivize or significantly penalize those individuals or hospitals or systems that don't make this a priority.
Yeah, I agree. And what I would say is, I think there's ample reason for cynicism. I remember when Katrina happened and New Orleans was devastated, and Americans, the media was shocked that something like poverty existed, that there were people who didn't have the means for leaving a city in the face of a devastating hurricane. And there was this idea that, we need to commit ourselves as a society to addressing this longstanding problem of poverty. And then, and then it kind of dissipated. And so there's a little piece of me that has a kind of skepticism about the willingness of a society to grapple with the revealed inequalities. At the same time, you do have a confluence of factors like that currently are part of Washington debate, like as we speak, which is some of the most far-reaching legislation that would be unimaginable 3 years ago, that deal with things like universal childcare, leveling the playing field, community college access. I mean, just a wide range of things that have unquestionable significance for for issues of equity, social equity. It reminds me of, to think historically for a second, the passage of Medicare, right? Where before Medicare was passed, the face of poverty in America was the elderly, people who hadn't saved money, who were retired. And through the Medicare program, what you did was you kind of transformed, regardless of questions of race and racial disparities, which were clearly pronounced among the elderly, it narrowed that gap considerably. And so there's something to be said, I think, for like large government programs at this juncture. And the other thing I would say is that a year ago, I was asked, like, what would be the implications of a pandemic? And I said, well, the one thing I can tell you is pandemics always strengthen the hand of government. Yes, we're going to debate the role of government, but there's a sense that this is a nationwide challenge that requires coordinated national effort. And suddenly every single state is dispensing vaccines and tests for free, right? Like, who could have imagined that we live in a society where you need a test, you get the test, and we don't worry about who pays for it. So that's my kind of hopeful spin, apart from the cynicism, that this becomes the basis for building a more robust and equitable healthcare system, a public health system.
So we had actually an additional question. Hold on a moment. Sorry. So this question is from Dr. Vieta Johnson, class of '82, orthopedic surgeon who has dedicated her career to serving the underserved. So how successful is your system, is a system that addresses the difficulties and hurdles that affects a socio-economically disadvantaged on a daily basis versus a one-time instruction on better food, but no realistic way to obtain the diet? So I guess this question is talking about recommendations versus actions and access, and allowing for access to, how do we shift that focus, really?
Yeah, it's a good question, and I think the answer is somewhat incremental. I would agree if the question is around how could a one-time, referral make a significant difference. I don't know. The nature of the question is, I would agree that that's probably just a starting point. But I think as a fellow physician, we talked about readmission rates many years ago, and first we recognized that a patient getting readmitted to a hospital after care for a particular problem within a period of time was evidence of poor quality. And we came to agreement about that. And then we started putting in penalties to improve the hospital discharge process so that people will be less likely to fall through the cracks. And then we penalized hospitals that didn't do that. And then we developed home-based technologies and visiting nurses and other structures to keep that patient safe and recognize problems early on. So I think that sometimes change is incremental. And so I would submit that at least having a system where social determinants are recognized is a step forward from where we are today. And unfortunately, I do think many of our colleagues in medicine don't, or not historically viewed, what happens to a patient once they leave their care or a hospital setting as their problem. And so we have to shift that up to the hospital. It is your issue to deal with. And it is our expectation that you will come up with mechanisms to address that patient's need. So I think we're starting this journey, and I'm actually pretty excited that it's going to move pretty quickly.
I guess I have an additional question, and it's been touched on a couple times, and it's another question from Dr. Johnson. So she was referring to the narrowing of vaccination rates. She asked how much of the narrowing of vaccination rates between the races is because of the federal and corporate mandates for vaccination completion to maintain employment. I think that that's also speaks to some of the discussions that we've been having about the government being able to address this on a larger scale. So, yeah.
You know, it's hard to tell. It's hard to explain exactly what has accounted for which changes. In some instances, we relied on people's self-interest to vaccinate. In other instances, we relied on their interest in those around them to vaccinate. In other instances, we created economic rewards, prizes, incentives. In other instances, we use the heavy hand of the threat of a loss of a job in particular kinds of industries, like in healthcare or in teaching. And I think the strategy, when people have asked, like, which of these work better, the answer is yes. That is, they all work. They work differently across the population, and they all need to be employed in order to make sure that, as many people are vaccinated as possible. And I guess in a former time, one might debate which one works better or which one accounts for more change. But really, when the urgency is to get as many people vaccinated as possible, you kind of pull out all the stops. And I want to add one other thing about this, which is good. It gets back to the role of government. The one thing that we've learned from the coronavirus, and certainly from the Delta variant and this Omicron variant, is that we're connected across the world. A variant shows up in whatever country, it's going to end up here. So your well-being hinges on whether or not everyone can get vaccinated, or the largest number of people. And I think that, the lesson of the vaccine then is that, as long as there are large pools of unvaccinated people anywhere in the world, this can have an impact on my well-being. And we're gonna see this play out over the next few months. And it's going to happen again. That there won't be, the number of variants that we have to deal with are, I'm a historian, not a futurist, but I can tell you that this story is not ending anytime soon. And that's just extrapolating from the last, 2 years, right? So these kinds of conversations about the role of government in safeguarding the health of the public will continue to be part, and the tools of government will continue to be part of our public conversation. And the disparity question, I want to think that it's here for the duration of certainly the pandemic, and hopefully we put into place structures that make this attention to racial disparities, institutional racism, kind of a permanent feature of how our healthcare system is organized, rather than just like a temporary fix.
Really good. All right, so I think we're coming close to the end of kind of our time here today. I'm going to take one last question, I believe, from Deborah. So the question she had is, we're seeing a spate of centers for health equity being developed or launched at many medical centers at key teaching hospitals in urban centers. And then she lists Harvard Teaching Hospital, Mass General, etc. What should their focus be going forward in regards to health equity, access to healthcare delivery, or understanding the causes and consequences of the social determinants of health and overcoming them? So what are some things that they do think would make sense for them to be focusing on in the future and as they develop?
So I'd certainly like to see, first of all, I think that's great And I think it should focus on, data collection. I think it should be like any other center in any other environment. It should focus on data collection. It should focus on outcomes. It should help us understand with scarce resources what are the best practice strategies to reduce health disparities. They should develop strategies that are reproducible in other settings. And so, but I think it probably will take them time because each will come up with probably their own slightly distinct mission. But there's a need to move quickly to address health disparities. So I'm hoping that there is a very practical focus to the work that these centers do.
Yeah, I think the challenge of living amidst a global pandemic that is still unfolding is how where's the silver lining? Like, where are the lessons that we can learn? And I would say that there are some really remarkable best practices with regard to lessening, reducing health inequities. They have to do with things like states that have decided that the vaccine rollout should be aimed at those who suffered disproportionately in the first stages. So that we should think about the distribution of resources not as everybody gets a shot, but we should think about it specifically with regard to reducing existing health inequalities. And some of these were shaped by some of these models for how you do ethical redistributive healthcare were shaped by institutions like Johns Hopkins and others. I think that, to me, there are some really fascinating examples of how you change the narrative of trust and distrust to being one about trustworthiness in the healthcare system, sort of like what makes a trustworthy healthcare system. So you move beyond these older narratives about groups that don't trust healthcare, which certainly is still there, to what kind of healthcare system is worth trusting. And there's some key examples, like while we're talking about African Americans, there's another example about how the rates for COVID among Native Americans were immensely high, and the death rate was 4 times the national average. And when the vaccine rolled out, the idea was, experts were saying, that the history of distrust of government that dates back to colonial times would mean suspicion of vaccines, and exactly the opposite happened. So that Native Americans are now the most vaccinated population. And it's because of long memory, but it's the long memory of the devastation of Native American communities from smallpox. That is to say that the decline of population due to epidemics in the past has left this long and scarring experience that made Native Americans more likely to be vaccinated. So, when I say there's silver linings in terms of how groups, we don't know exactly how groups will respond, and the past is not always prologue or predictive of the future, and looking for opportunities to actually build trustworthiness or build on the advances, as in, like, how did we reduce these disparities in vaccination rates, and how do you keep building on them in terms of addressing other health inequities? These are the kinds of things that I think we should focus on, both in healthcare, in public health, and as a society and in government.
Wow, that was, I really actually like the comment of trustworthiness. I really love that in terms of like a pivot in thought about how we think about our systems in general, if they're worthy of trust. So yeah. So we are coming to the close of the time. I don't want to take too much additional time. So I figured that for closing remarks, if Dr. Kountz, if you'd like to do you have any closing remarks that you'd like to leave us with for this discussion?
I do. First of all, thank you all for your comments and engagement. Professor Wallow, it was a real pleasure and honor to be able to chat with you. I guess I am somewhat optimistic despite a lot of negative statistics we've talked about. I think back 35 or 40 years in healthcare when no one thought that we needed to focus on patient safety because we assumed that care in hospitals was safe. We learned that it was really important to create an infrastructure to address safety and quality. And I'm hoping we're at the beginning to understand that we can't take that health inequities exist, that we can't take it for granted. And so our conversations about structures and focus today will become embedded in the system. And by the end of my career, there will be individuals, actually not even the end of my career, we've hired a vice president for social determinants of health, that there'll be sections of the healthcare system fully devoted, accountable, and increasingly visible across the country, around the world, addressing healthcare disparities. So I'm hoping with all that has happened with the beginning of what will be a very long-standing movement that grows in momentum, that increases in momentum.
I couldn't agree more, and that's all I would want to add.
Thank you both so much for taking the time to share your expertise and your thoughts and kind of guiding us through this discussion. Our community is honestly richer for this discussion, and I really appreciate this. So I know that you're all interested in hearing more about ABPA happenings. So I just wanted to make sure that you all knew about a couple upcoming events and items. So I do know, I believe, and one of my co-chairs can confirm this for me, but I believe that we will be doing a career panel in the future. So be on the lookout for that. Otherwise, we will have our newsletter that will be getting released with more events like these and more chances for us to be able to learn and grow with each other and find ways of like impacting and learning more about and finding ways of impacting our communities and learning more about how we can talk to each other and kind of speak on a more general basis. Anyways, I just wanted to say thank you so much for joining. This was honestly really exciting to be able to have this discussion with both of you. And I really appreciate all of the questions from the audience. So yeah. Anyways, I will be hanging out on here for a little bit, but yes.
Thank you. And thank you, Dr. Kountz, so much.
Good night, everybody.
Good night.
Thank you so much. Good night.
Take care,
Good
everyone.
night. Thank you.